Healthcare. It is Wednesday, April 9th. And we're going to start concentrating on S-126. My hope is that we kind of break this into sections and sections that sort of relate to each other. So we would start with sections 2 and 3. They have to do with Green Mountain Care Board and rate setting ability. So let's get an overview from our system of care about how rates are currently, how they're set, how they're different, so that we can be thinking critically about if they should go in the future. So we're going to start with healthcare advocate, Mr. Fisher.
Didn't realize I was going first and wasn't hanging on every word you just said. So
just ad lib.
Mike Fisher, healthcare advocate. Thanks. I feel like I spent a little time with you guys lately. So focusing on sections 2 and 3 on provider rate setting and reference-based pricing. We think this is the most important section of the bill.
Whoa.
A key section of the bill, and we think it's really important to get it right. And that the language that's currently drafted is a bit confusing. It is in our mind, a provider rate setting tool. It is not a payer regulation in any way. And that it's very important to get that right, because if it is framed as a regulation of payers, we all know that there's only a handful of payers the state gets to regulate, and the fully regulated market, the small group and individual group and large group, and leaving off the self-funded and Part C. And so if it is framed up as fully as a provider rate setting tool, we are in effect saying, here's what providers are allowed to charge, and it doesn't matter who's purchasing it. So that's the high level statement about the sections 2 and 3. And we think that there needs to be a small adjustment of language to be super clear about that.
Where? Yeah, Alan.
Okay, so you say you set a rate. What if we set a rate and the provider doesn't agree with you?
So, thank you. That's where I wanted to go next. This sort of, in theory, sounds simple, but in practice, I guess I want to go back to a slide I had yesterday that had the dates of this year's regulation in front of us and the challenges we have directly in front of us. I kind of wanted to respond a little bit to a conversation that happened in here about the board's authority and who checks on the board, and to stare a little bit more directly at the financial challenge that's in front of us. We set up the board as an independent entity very consciously. Before the Affordable Care Act, before the Green Mountain Care Board, we had hospital budgets were done in a different way, but insurance rate review was done at the then called BISCA at DFR, the same entity that's now DFR. I'll just say, when I sat at the other end of that table, and we saw decisions by DFR, we often didn't know exactly how they came to be, and they weren't. I'll just say personally, let me use a Democratic administration just to make the point. When Governor Shumlin's commissioner of DFR said Blue Cross gets 3.5%, we sort of turned to each other and said, what was the process? Was it clean? What was the political influence? Just to be sort of extreme in it, was that written on a napkin in the governor's office? We don't know. And so we really intentionally set up an independent body with an independent process, with as transparent as possible a process, so that we could all watch it. I have been as frustrated as can be about decisions that the Green Mountain Care Board has done over the last 12 years or whatever it's been. And people have often asked me, like, aren't you mad at the board because they didn't do it? And I always want to be careful. Like in a court, I can be upset with the decisions, but I don't want to be upset. Like the process is important. And so today can be frustrated with decisions that the board is making. For instance, I think they got it wrong on their hospital budget guidance. I think it's important that they look at given our financial crisis, I think that they need to look at the guidance again because I think it boxes us in. But that's a process comment, not a criticism of the structure of the board. The board makes its decisions in public, and we all get to see it, and we get to hear their deliberations. And yes, we are in a financial crisis. The hospitals are likely to ask for dollars that will lead to rates that will drive small businesses out of business and taxpayers out of the ability to pay their taxes. And so I don't run a hospital. I don't know what it's like to run a hospital. And so, no fault to community hospitals. They're doing their very best to figure out how to make it work. That's their job. I'm looking at the whole system and recognizing that these are going to be really hard decisions and decisions I don't want to have to make about the availability of care in our communities. But my biggest my fear isn't just that we're overspending or that we can't afford the care. My fear at the moment is that we're not paying for the care. In other words, we're driving towards insolvency. And so, yes, your question is on target. What happens if hospitals tell us they need more money to deliver services than we can afford? I think that is exactly the place we're in.
I see you, Woody, but can I expand on sort of what you've been talking about a little bit? Because as I'm thinking about this bill, as I'm reading, and frankly, in a lot of the things that we do in this committee, we talk about the value of the board and their independence. But we seem to have a very disjointed regulatory guidance. If the board will take an action around rates for an insurer, and yet we have the Department of Financial Regulation that has a competing interest of who's looking out for the solvency of the insurer.
Right.
We have AHS that is, looking out for, what about the goals of healthcare reform? And that's just an example. This bill has a statewide healthcare delivery plan. Do you think we have a statewide healthcare administration plan?
Yeah, your point is what
We start with maybe that.
your point is accurate. It does feel disjointed, and we've got a lot of planning in place now, but not enforceable planning, not planning that drives other decisions directly. The way the language, DFR advises the board on the solvency question. I've been frustrated over the years by that dynamic as well. But at the end of the day, the board is tasked with again, I'm going to say balancing the competing needs of solvency and affordability. And, over the years, from Anya Wallach to Gobet to Mullen, the previous board members, I've been frustrated that the board has, in my opinion, not put enough pressure on healthcare costs. The board gave hospitals, was it 98 or 99% of what was asked over all those years? And I think that's part of the dynamic that leads us to where we are now. We have not been really regulating the increased costs, in my opinion. Yeah, it does feel disjointed. And I'll just say something else that feels disjointed. I don't get it. Costs at hospitals and providers leads directly into insurance costs, directly. And yet people have this concept or this, people can say, oh, my hospital needs more money, but I don't think rates should go up. Insurance rates should go up. And that's baffling to me that people don't understand that this is one equation. They lead directly into it. We regulate insurance companies and their administrative costs, and we look at their books in an entirely different way than we do hospitals. We scrub them in a different way in the insurance rate review process than we come anywhere close to in our hospital budget process. That isn't to say that I don't think our insurance companies haven't made, I'm not sure I said that sentence right. I think our insurance companies have made mistakes in business decisions in the past that I feel very critical of. So I don't want to give anybody a pass here. But we are indeed in a tremendous crisis that does play out all the way down to the level of how much do we have to pay providers for our care. And it doesn't matter whether it's rate or it's increased utilization. It's still money that we need to come up with.
Did you?
I was just going to say the reference-based pricing.
Mm-hmm.
I think one of the criticisms towards that is its price control.
Mm-hmm.
And there's good parts of that as well as negative aspects of it.
Right.
And that's what I'll leave it at that.
And so I may respond, I think we have a stark choice in front of us. Either we find a way of managing the costs or the market will manage our
Well,
infrastructure.
there's some that would say, let the market make that decision.
And my fear
Yeah.
or expectation is that the market will be far more brutal to our communities
Than any board.
than we would be if we were planful. Maybe we can't afford a full hospital as it is today in a community. And maybe we need I don't know, let the experts decide. Maybe we need something that's stepped down, but a real healthcare facility that's going to meet people's needs. That's something you get to do if you plan for it. If the market does it, it just shuts down. They run out of money, they go bankrupt. Creditors are trying to get their money out of it. It's messy. I want to avoid that. That's the worst case scenario.
Market.
Yeah. And again, the slide with the dates that we had yesterday, it's this year. There are a handful of hospitals that are going to, that I think will ask for rate increases in order to stay solvent for the coming year that the board is going to have to face. I don't know how we're going to pay for it. And so, but you're absolutely right. Provider rate setting is provider rate setting.
It's price control.
Yes.
Well, can you talk for a minute about how healthcare is not a typical commodity market? The problems in that?
It's,
That's the struggle.
I mean, that is part of the struggle, both, multiple parts of it. Nobody should be deciding to forego care that they need. Whereas if you, I don't know, I'd like to replace my car, but I kind of can't afford it.
Want to be
It's
dressed for the prom.
totally different dynamic. And the consequences of not getting the care that your provider says you need is worse health outcomes and more expense. And the dynamic with a third-party payer is different than anything else, anywhere else in any other market. It just behaves differently.
Wild consolidation.
Anyway, I fully support sections 2 and 3. There's a detail in section 3. I apologize. I wish I had been more prepared for this. I want to recognize that the concept of a global budget for us is a step later in this process. I don't support a global budget based on prices that are out of whack. And so I think we have to get the prices right before we move to a global budget. And all of the discussions about global budget for ahead, hey, I sat through, I don't know, thousands of hours about global budgets methodology in the last couple of months. But they were all built on current rates and therefore built into the concept of the global budget, the inequity of our current rates.
So sections 2 and 3 revolve around reference-based pricing. And then there's pieces about global budgets.
Mhm.
Could you talk about, well, I know you can because you can talk about anything.
Yeah.
Can you talk about site neutral payments?
Yeah.
This is something that I don't think we've talked about in this iteration
No.
of this committee, but in the past.
Right. I can almost feel the provider advocates around the room squirming around some of this conversation. I just want to acknowledge this is all hard. And everyone's used to figuring out how to make it with the status quo. And so when we talk about changes, it's hard. But I have a theory about how to make this stuff work with reference-based pricing. I have a theory about how to right price between hospitals and right price between areas of care that we want, categories of care that we want to make sure we support: primary care, mental health. I have a theory about how to incent care between hospital and non-hospital with the reference-based pricing tool. I don't have a theory about how to do any of that stuff without it. I think the board, in effect, tries to without it, but I think it's a key tool that has to be used right and carefully. But it's a key tool in driving each of those, sort of directing money where we think it needs to go in our healthcare system.
Would you agree, though, that because we've sort of incentivized through hospital budget review, that we've actually incentivized a more expensive care, same services, more expensive care?
Yes, absolutely.
And without site neutral adjustments.
But let me say it really directly. I have a fear that the regulation of hospitals over the years has assured hospitals get increases that independents have had no assurance, no protection about. It's only so many dollars to go around. And so at the end of the day, the carrier has to say, I got to give this much to the hospitals, to this and that hospital and that hospital, and that there's been just crumbs left for the independents. I have a real fear that that is part of what has played out.
Do you think it's consolidating more of that within hospitals, so it just ends up being more expensive? I mean, like feeding upon itself.
I can see that that would be an outcome of that dynamic. I know that the chair has described, I have no independent way, Chair Foster has described, I have no independent way of checking it, but it has described in the last year or maybe the last 2 years that the downward pressure on hospital spending has resulted in more monies being able to go to independents.
All right.
I'm gonna change the topic a little bit, still reference-based pricing, but I'm I don't know if you heard me yesterday, I'm still thinking about reference-based pricing.
Yeah.
Public sector employees, and being able to help help those folks, and bring the costs down in those plans, which would help our system. Why not? Why or why not? It seems like a good
Yeah.
first step in going to full reference-based pricing. I'd like to hear the advocate's position on that.
So first off, fair disclosure, I am on the VHI plan. Should let everyone know that now and then. My wife's a school employee. I have well, a certain logic to it. Taxpayers pay for those plans, and taxpayers are feeling particularly pressured today, and I certainly want to do everything we can to give taxpayers relief. Small businesses are in a very similar, are feeling very much that same pressure and are really in trouble. I mean, our provider communities that as small businesses are figuring out, are showing stress and closing at times because they can't. So to sort of politically, let me first say, I don't know how you say, hey, let's do it for these guys. I know you're bleeding over here too, but I'm not going to address your need until later or initially. So that's sort of on the political level, but on the policy level, on the sort of impacts of the system, wherever you do or you apply a fix in one place of this messy system, there's real risk of it ballooning is the term we use, the reference we use out into other places. And so, I think I would just have a real concern about whether the costs that you put downward pressure on for the public employees would show up elsewhere in the system for the small businesses.
In the individuals
Yes.
on the exchange.
So that's a fear. The right question in response to it is, can you regulate that out of it? Can you regulate yourself out of that? I don't know. Maybe in theory, I've been around long enough to see us fail in efforts like that, or not do a good enough job. So I think if to the extent that we need to work our way into reference-based pricing because it's too much of a shock for the system, I think it needs to be done system-wide, but stepping our way into it. Maybe by areas of care rather than payer groups, how to say it.
Because that's the thought behind it, that it would be a way of stepping into it, especially if we could roll it out so that it happens closely together and not.
Yeah. I think the right.
In a time between when different areas. were-
Yeah, my response has been that it makes sense to do it system-wide rather than public employees. Yeah. I understand the motivation to do it that way, and I understand that it's being seen as a sort of a stepping stone into full reference-based pricing.
And it could be potentially done faster.
Yeah, I think what's before you is a bill that gives the board, let's just be clear, the board has this authority already. They have been scared to death of using it ever since they were given it. And we have written, I don't know, probably 100 comments to the board that the only way out of this is to employ their provider rate setting. If you look at the HCA comments over the years about the challenges in this regulatory issue or that one, But, but what's before you is a bill that gives the board some staff to do it and tells them they have to move towards it, gives them a timeline that they have to do it by. And I think that's the right answer, is to tell the board to staff up and become experts on how to do it. And let the experts decide exactly how to roll it out.
Did you, yeah, I'm not sure you're ready for this question, so, but I'm curious about how you shift this language to what you're talking from.
There's a reference, maybe future witnesses kind of plan to talk about this. Yes, I think so. There's a reference in, and I apologize again that I'm not prepared for this, that about how much insurers will pay is a reference to insurers paying. And I think it just needs to be as clear as possible that this is about what providers shall charge.
Thank you.
Thank you.
Jessica.
Thank you. Jessica Barnard with the Vermont Medical Society. I do, at least on one version of the agenda, I have an MD before my name. I want to be clear. I am not a physician. I am an attorney. So I cannot give anyone any medical advice.
Yeah.
I am actually going to try, sorry, I didn't do this earlier, try to join the Zoom so I can walk through. I didn't do, it's not slides, but a memo as we go. So let's see if I can do this without getting feedback. Oh, yay, it worked. Okay. So again, Jessica Barnard with the Vermont Medical Society, representing physicians at different practice settings. And I understand the request was to kind of do some 101 of what reimbursement methodologies are currently used in, at least for our case, physician practices so what I will say is that what I'm going to talk about this morning is about professional services. So it's actually not just physicians, it's the individual payment for provider services. So your physician, your PA, your nurse practitioner, your psychologist, your therapist, like generally these are how professional services are paid for. I'm also going to focus on the fee for service payments for those services. So I know you've heard various other speakers this session. There are many other methodologies of paying, capitated payments, so a lump sum for a certain amount of care, value-based payments, so saying, we will adjust what we pay you based on your quality outcomes, bundled payments, saying you've done X surgery, or for example, a lot of labor and delivery services. So is your one payment prenatal care, delivery, the visits post-delivery, those are all in one bundle. There are also, I'm not going to talk a lot about also the facility fee piece or hospital, direct hospital payments for inpatient or outpatient services. So I think Boz will get a little bit into those issues. So again, these are, X provider provides the service, how are they paid? And I'll then I will try to relate this to the rate setting in the bill and our comments on sections 2 and 3 of the bill also. So I'm going to start with Medicare because a lot of other payments from other types of providers actually adopt the Medicare methodology. I will give you a little bit of math. I did check this as an example of how, so Medicare does an annual rulemaking to set how they pay providers under their profession. They call it their physician fee schedule, but again, it's not just for physicians, it's for the professional fee schedule. They take in all sorts of data, information. There are numerous committees and processes that feed into this rulemaking and this formula that comes up with, they look at, they consider how much work goes into a service. So how much time it might take to provide a service, the practice expense. So that's things like overhead, your staff, your office space, the malpractice cost of providing a service. In each of those three buckets, they then adjust for your geography. Where are you located in the country? How expensive do we think it is to offer services in your country? So each of those three components get a number assigned to it. So I've given this example. It was one I found online, so I just used it. Fine needle aspiration, so a procedure, and that has a service code, a CPT code, and then they give a number. So the amount of work is 1.03. The amount of practice expense, 0.426. The amount of malpractice, 0.121. That gives you a whole number, or a decimal. Then how to get that and how much translate that into how much you get paid for that service, they multiply that by something called a conversion factor. So that's the dollar amount. So they add up those numbers, multiply by a dollar amount, and out spits, for this code, we pay you this much. And they go through that for basically every single CPT code there is. Yeah.
Are there different RVUs, whether it's a physician, APRN, a PA?
No, though some payers, not within that portion of the calculation, in some fee schedules, there is a different conversion factor applied. So I don't believe the RVUs are any different. That would be the same for everyone, but there are some, like for example, in Vermont Medicaid, actually, they do use an 80%, I believe is the number, conversion factor for nurse practitioners and PAs compared to a physician, but they don't adjust the RVU calculation, is my understanding.
Thank you.
How that's done. Yeah. And there is a different, again, I said I wouldn't go too far down the facility fee line because I'm not really an expert in that area, but I will say my understanding is there is also a different conversion factor if the service is provided in a hospital facility versus a non-facility, what they call like an office-based setting. And actually that conversion factor in general, though I think it may vary, is lower for the facility. So the facility professional payment is actually lower because they then also get a facility fee in addition. So they sort of say, well, your practice expense as the professional is lower because you're located in this big facility, but then we add on a facility fee for that. So they kind of get two payments that add up to a bigger payment, but the professional's payment alone is actually often lower in a hospital setting under the Medicare fee schedule.
How about inpatient versus outpatient?
I think that I'm not an expert on how those are two totally different fee schedules, separate from the professional fee schedule. They have their own inpatient fee schedule, own outpatient fee schedule. And I think those are set differently, and I think tend to be higher than the professional, because those are also tend to be, well, yeah, I think those tend to be higher than the professional.
Are you referring to professional fees
Yes.
that based on whether the patient though is in inpatient or outpatient?
Yes.
That would be the same fee schedule, the professional fee schedule, but there could be a different facility versus non-facility conversion factor. Does that make sense? So the provider service is the same. The provider may get a different amount based on whether they're getting the facility or non-facility conversion factor under this. But then my understanding is the inpatient and outpatient separate fee schedules for a hospital are all about the facility fee more than the professional fee. Because then the professional gets this payment for the professional time doing an office visit. Well, an office visit is a bad example because that would only be a professional fee. But well, no, it wouldn't. So there would be say it's an office visit at an E&M code. My understanding is then the professional gets paid under this fee schedule, but then the facility may also get a payment under the outpatient facility fee schedule that is calculated in a way I don't know because I'm not an expert in the facility fee schedule. So there's a whole separate fee schedule for the facility fee component. Did that make sense, or did that?
It did, it just points to the complexity.
It is very complex. There are multiple payments even for the same service, and it depends on where it's located. And yeah, it is very, and this is all still just under Medicare. We're still just talking about one payer. They have multiple ways of paying. Yes. Ready to, did you have a question?
No,
Okay.
it's really important that we understand how Medicare pays, because that's what reference-based pricing
Is
is.
based on,
Based
yes.
on.
And I'm going to get, oh, go ahead.
Yeah, Leslie.
I'm curious to know that in this scenario, what is Medicare billed by this physician? Or this, like, what? So the pricing might be going down from $500 to $53. You know how we see that? I'm just curious to know what the cost of fine needle aspiration is assumed to be in the practice and what Medicare reimburses for it.
Right. They will pay this regardless of what it costs you to provide. And their
But,
theory,
there's a
right, there is a different, their theory or their, they CMS, when they
Okay.
build this fee schedule, will say, we have taken that all into account in how we calculate the work and practice expense and malpractice RVUs. That is the intent. And they do in every 5 year, every so often, I don't quote me on the number of years, an actual survey of practices. They'll send it out to thousands of providers around the country. How long does it take you to do this? How many staff do you need to help you to do this? They try to gather that information, but there is always an argument that it is not actually truly reflecting the cost of providing the care. Or maybe it's high, maybe it's low, and again, these get adjusted every single year. They go in and adjust these RVUs. But only every so often do they do this big survey. There's a big, and this has come up in this committee, I know, there's a big argument that the way Medicare has valued things like an office visit or psychotherapy is much lower than, say, procedural-based codes and payments. And over time, CMS has tried to make some of those adjustments and increase the more office-based visits, decrease some of the procedural, but then that leads to other sort of complexities, which I will get to in a minute. But they do try to adjust these. They say it reflects the real cost of providing the service, but certainly providers may disagree on that, comment every year on how they're adjusting RVUs, whether they're good or accurate or not accurate. There's a lot of back and forth on how accurate they are estimating actual costs. But unlike a commercial payer, you're not getting paid, what you are getting paid is not based off of what you bill in any way. You could say this cost me $300 to provide that service. What you're paid is not based on that $300. It's based on Medicare saying, well, here's what we think it should cost. We're giving you this. And then
They're all losing money, sorry.
and we'll also say, and then there have been a lot of critiques of how Congress, so there's this rulemaking by CMS. Congress has also put various parameters around the fee schedules that Medicare pays. And one consequence right now is that Congress has stated that the Medicare physician fee schedule is required to be budget neutral. So that means if they make an increase somewhere in the formula, they have to make other decreases elsewhere. I'll caveat that they actually say there's a $20 million flexibility, but when we're talking about congressional numbers, that's basically nothing. So when they have been trying to increase the RVUs for office-based services and say, yeah, we agree with you, you primary care, office-based services, you should be getting more, that has required them to make decreases elsewhere. And one way they have actually implemented that decrease is to decrease that conversion factor. So think, okay, sure, you get more RVUs here. We're actually going to then across the board pay less for everything else to offset that increase. So a consequence of that, there's actually been year-over-year decreases to the professional service fee schedule. So I gave some examples. 2024, there was a 3.4% cut. This year, there was a 2.83% cut. And CMS, who does the rulemaking, is saying we agree. We basically agree. Actually, CMS has kind of come out and said this is a problem, but Congress needs to change this. Congress has said it needs to be budget neutral. This requires legislative change. And as we know, changing anything in Congress, very hard right now. There have been a number of quite bipartisan bills to fix the Medicare professional fee schedule, but none have gotten across the finish line. This professional fee schedule also does not receive any inflationary adjustment. So putting all these factors together, the AMA, the American Medical Association, who works a lot on this issue, estimates that the Medicare professional payments under this fee schedule have actually declined 33% from 2001 to 2025. So that's showing, practice cost inflation and then the actual updates to this fee schedule. Even if those, and again, even if under the RVUs, they're saying, yep, we agree, costs of providing these services have gone up, because of the budget neutrality requirement, they really can't overall increase this fee schedule. So it's been a problem that nationally there's been a lot of advocacy on. And then I'll talk about how that trickles down into the Vermont Medicaid fee schedule. And so it's one issue we're really paying attention to when we hear reference-based pricing and referencing Medicare as your benchmark. You have to then start paying a lot of attention to what Medicare is doing. I didn't, sort of became, all of a sudden I realized, oh, I can't just focus advocacy on Vermont work. Like if we are not advocating around how we fix the Medicare fee schedule and we are benchmarked, and I'll get to this, Medicaid is largely benchmarked to Medicare for professional services. That means all of a sudden any change Medicare makes, whether it's in the RVUs, the conversion factors, what they're paying means if we are saying we have to benchmark to it and holding ourselves to that, we are basically linking ourselves to Congress and CMS. That's the decision we're making as a policy decision. And we then, unless we give ourselves some flexibility, are beholden to that. So that was all Medicare. Medicaid's, again, this is the professional fee schedule for provider services. They call that their RVS fee schedule, resource-based relative value scale. It's very similar. They go through a rulemaking each year after CMS and Medicare finalizes their fee schedule. Medicaid looks at how Medicare has adjusted their RVUs and their geographic adjustments and generally adopts those. And I think for good reasons, as let's be consistent, Medicare has this big process with all this input to adjust all these factors. We don't really necessarily want or have the capacity in Vermont to go through a whole different process, sort of set up a whole different methodology for a fee schedule for professional services here in Vermont. Let's align with those calculations of what it costs to provide a service. They then apply their own conversion factors. They have to say, let's translate that number into what Vermont Medicaid pays. As of current 2025 conversion factors, the way the math works out is that Medicaid currently is reimbursing at about 115% of Medicare rates for their enhanced primary care fee schedule. So certain providers providing certain primary care codes actually receive now above Medicare rates. The remainder of services, so that's all specialty care services and primary care services not sort of under this enhanced rate, get around 89 or 89.5% of Medicare rates currently. For the years, when Medicaid was really having as its goal benchmarking to 100% of Medicare rates, that's when we really ran into this challenge of, well, but Medicare is going down year over year. That's actually leading to year over year cuts to Medicaid as well. So because of this, we support, there is currently language in S126 allowing the board to opt to update reference-based pricing after setting it initially at a reasonable rate of growth that is separate from Medicare rates. And I think that is a very good idea. I actually think perhaps it should be mandatory rather than optional, I guess, if Medicare is going down year over year. But I think at least allowing that flexibility to say, we benchmarked initially to Medicare, but let's allow a growth rate in case Medicare is actually decreasing.
So that's two.
That is in section 3E, I think I noted down. Let's see.
Yeah. Section 3E.
And that's to, so yeah, so just
Okay,
to,
June.
I can remember that.
Sorry.
It is. Okay.
It's a bit. So legislative council, hold on. I will look, I was looking at the bill as we were not, but I think it's in section 3. Page three E2A.
Yes, bottom of page 6, at the very bottom.
Board may opt to update.
Yes.
Okay.
And that is not, I want to be clear, that's not necessarily true in all of Medicare's fee schedules. So they're currently their hospital and I believe inpatient and outpatient fee schedules do have some kind of annual inflationary adjustment. But again, their professional fee schedule does not. Okay, so we've covered Medicare, Medicaid. Commercial is really it's an individual contract between any payer and any provider. And there's often the statement they're, negotiated contracts. In theory, that is somewhat true, but the fee schedules there's often one community fee schedule from larger payers that individual providers either choose to accept or not. So while in theory, you could try to do some negotiating for most of the larger payers, there's not really much of a negotiation. It's sort of, you provider, do you want to participate in X plan or with contract with X payer? If you do, here is our community fee schedule. Here's what we pay you for these services. And here's the rest of our contract language. I did, in case it was useful, because since again, we're kind of talking about benchmarking, I included some data on roughly on average if you looked at a benchmark to Medicare rates, commercial payers pay for, and again, this is for professional services, not the inpatient and outpatient hospital services. So depending on the analysis you look at, it's sort of around 143% with ranging from 118 to 179. So again, commercial does pay generally over Medicare rates. And so I included just a couple analyses of that. And then states that have benchmarked, this is usually in state public option programs. And we talked a little bit about that in this committee last year when you were looking at a Medicaid expansion. They have tried to set reimbursement rates for professional services closer to commercial rates rather than benchmark to say 100% of Medicare or something like that. So sort of in the 130 to 160% of Medicare. So we do have some, I would say our overall position on reference-based pricing is as good as what you set the reference-based price at. It could either be a very effective way to sort of reduce payments to the extent that providers can't continue to operate, or it could be helpful. It depends what the benchmark is and how it is set. It is kind of what it's as good as what that rate is determined to be, and it can provide different tools depending on what your policy desire is. Are you just looking to save money and then just pay less, or are you looking to increase stability or even incent certain types of program? Do you want to incent a provider to offer more primary care services or mental health services? So it's really what are your policy goals and how do you accomplish that through what you pay for a service? It's kind of, I would say it's almost a neutral policy choice depending on how you use it. So we do think it's important, for example, in section 3 to list some factors to use to determine reference-based prices. What are your goals? What factors should be considered? How granular can it be? Is it 1% for every single service offered? Or again, are you using some nuance and looking to see what you want to incentivize?
I think Woody has a question.
It just had to do with setting the proper rate. How are we going to ensure that reference-based pricing is based on the right rate? And I know you gave examples of what we want to do, but that just doesn't seem enough to me. There should be something that we are all looking at, wanting to desire for our healthcare in Vermont, and therefore the rate should be set on that particular goal. It just seems kind of
I
wishy-washy.
agree with that. I think it's a great thing to ask the various witnesses who you have coming, sort of what they think and what you think. Again, is the goal simply to reduce commercial premiums and just pay everybody less? Or is the goal also to ensure some stability for our hospitals? Is it to ensure sort of equity between what we're paying for services? I think, again, I think it depends. I do think, I've heard, I certainly won't want to speak for them. I think Blue Cross has testified before on reference-based pricing in general. There are some services that really are more comparable between where they're offered. Let's say we're talking, I'm going to make this up, a CAT scan. Do we really think the cost of offering that in X location should be that different than Y location? So maybe that's a more easy example to start with than some complex procedure that may only even be offered in a couple of facilities in Vermont. So I do think it's complicated. I do think it's useful in the bill to specify some sort of goals and factors for the Green Mountain Care Board to kind of give them some direction. And I also think that's why it takes some time. I don't think this should be rushed. I think there should be a lot of stakeholder input and rulemaking to kind of flesh all this out, because I don't think these are very simple answers to land on.
But we don't have the time, really.
And I don't know if you
Time's
necessarily
running out.
want to decide all of that yourselves. I mean, there may be a value in leaving some of that to, say, a rulemaking process for all of the stakeholders to give more input on and kind of give more time to design that, because it is complicated to answer. I do think also, again, talking a little more about guardrails, I think it's important, and maybe again, this committee could build off of this a little bit. There's one sort of brief line in the current bill around factors to weigh in determining whether to continue, or I think it's actually phrased as ending reference-based pricing, for example, leading to reduced access or quality. So I think there should be some check back in, is this working? And when do we say this is not working or end this program, possibly even being clear about starting as a pilot in some locations or with some services to see what the impact is. Then I'll also comment, there is a paragraph, there's section 3E5 regarding establishing reference-based pricing for non-hospital services. I think, having watched this bill develop in the Senate, this language got changed at the very end, and I believe was kind of combining a couple concepts in a way that is, in my view, not particularly clear. I think it's also not entirely clear with the current language, what the goal is here. I think there was an initial intent in the Senate to look at, could it be a tool to actually increase reimbursement to primary care services? But the final language is very broad and a little unclear to me what type of services or providers they are referencing. Are they really just talking about, say, professional services for primary care? Or is this every type of provider that exists in the world, mental health, home health, dental services? AHS really already sets Medicaid rates for those payers. They already do that. I'm not sure they need additional authority or request to do so. If we're talking about commercial, is this limited to commercial payers? That's also not really specified in this language. Again, I think I believe this section is either not really necessary, or if this committee really wants to go in some direction of reference-based pricing for other providers, really think about which providers and why, and then which entity would be the one to regulate that. Our recommendation is actually to replace that with a more holistic approach to alternative payments for primary care services. And I know I heard the Chair Lyons comment that that's one area that the bill could potentially do a little more in. We support doing some more in this direction. We are concerned that with the loss of the ACO and lack of clarity or knowledge of whether a head is happening, not only we know we've talked to this committee about payment rates or losses of payment, but also some loss of infrastructure for alternative payments to primary care. So we would like to see AHS work with primary care organizations to really develop, to work with us to develop an alternative payment model, such as per member per month payments or capitated payments for primary care. We suggested a date of January 1, 2027, knowing that either that could mean we are building something leading to a head, or if a head is not happening, we're getting plans in place regardless for how could we pay primary care differently, how could we bring together the streams of Blueprint, the ones that were OneCare. I mean, we sort of right now have all these little pots of money that are going to primary care. Can we really look more holistically, get everybody around the table? How do we bring this together in kind of a more integrated way, what we've heard from primary care practices is not only how much they are paid matters, but really the form of payment matters. And for example, the comprehensive payment reform program we've talked to you about for independent primary care, the value of that has been not only enhanced payments, but sort of one chunk of a capitated payment that then gives them more flexibility to provide services in a way that's more creative, bring in mental health staff, case management staff, and not just be chasing these little teeny buckets of money that all have different, requirements for reporting and things like that.
Brian?
I have 3 questions. One is, when you talk about primary care providers, what is your definition?
Vermont has several definitions of
Yes.
primary care. I think flexible. I mean, I don't know, payment currently, I will say, is very different, for example, for mental health providers than primary care provider, the current funding streams and funding methodologies. I think it may be difficult to create one payment stream for all types of providers who are providing primary types of services. I think in some definitions, absolutely, mental health should be included, psychiatry should be included. The way Vermont has typically defined it is both a subset of provider types and a subset of services offered by those providers. Do you want to keep those, definitions? That's the ahead primary care payments kind of keep that more limited definition of primary care, I would say. We often advocate for OB services to be included in that. Often they are not. I think that could be, that we are intentionally suggesting some pretty open-ended language around bringing the interested parties together to talk about this, to look at what might make sense. I personally think that certainly integrated services, so mental health, substance use disorder, reproductive health services offered in a primary care setting or clinic should be considered part of that payment. Whether that means does that make sense? So like if it's offered in the primary care medical home, a broad range of services should be included as part of that.
Yes, kind of like how Hub and Spoke works.
Yeah, right. Or how the blueprint works.
Yes. And so the second question is, using the definition of primary care provider in this moment as a medical home or as an MD or, a doctor or group of doctors around which other services are clustered, not like a private mental health counselor or other services that could be considered primary care. Just using the definition of MDs providing, the family medicine. I don't know what the right language is, but you get the point. Do we know how much it costs approximately per year? I know it changes year to year to support that inside. Like, what would the number be if
That is a.
Elon Musk gave Vermont a donation to support our entire primary care visit?
Right, just
We'll
give
use that
X,
one.
just give X practice,
Yeah.
X amount of dollars, and you go to your
We're gonna
thing.
give every primary care, it's the greatest primary care system in the country. We're gonna give every provider exactly what they need to stay open and thrive for a year. Like, what would that number be?
That is a great question. I think the best way I can't answer that off the top of my head. The closest I could probably get is to look at what those CPR practices are getting from OneCare currently, because that's sort of the best attempt that is actually in place to say, here, practice, this is what we think you need to run. And it's complicated, right? Because some primary care offers X-ray and lab services, some do not, some offer. So even in that program, there's been kind of a capitated piece and a fee-for-service piece.
Yeah.
Because even what a medical home does is different from medical home to medical, like the FQHCs do translation services and, food and transportation. So you would think there would be a nice, easy number to answer that question. It may not be that simple, but I could get you something.
Yeah, or like a foundation number and then
Right.
estimates of like
Right.
I don't know.
What on top of
Yeah.
that do you need? Yeah.
Yeah, and then the third question, sort of, I guess it's one question, is if, I'm trying to make it into a question, if Vermont made the policy decision to create a universal primary care system where we guaranteed access to primary care and the solvency of the network of medical homes to start, not all the frosting on the cake, but like just the cake or whatever. I'm sorry, I have a cake in front of me, so thinking of a cake. is that compatible with AHEAD? With the AHEAD model? Would that be, if like we went in that direction and AHEAD happened, might it be compatible from your knowledge? Or would we be going in a direction where suddenly we'd have to be like, oh, wait a minute, now we've gone too far from what AHEAD allows? I suppose we could abandon it.
I think I'm gonna answer that in a, so I think AHEAD still gives the state a lot of flexibility. Really, all AHEAD does for primary care is say, for each Medicare patient you see, you get a monthly payment. That's really all the primary care component is of AHEAD.
Okay.
It's a monthly per patient payment for your fee for service Medicare patients. They actually say, you state, tell us what you're going to do for your Medicaid component of this. And Medicaid and what Medicaid is currently saying is largely that will be the blueprint, like a continuation of the blueprint. That is a very, I think it depends what you're meaning by a universal primary care program. If you're saying a universal primary care payment mechanism, or are you saying a universal primary care insurance system? And I will say my concern with creating a new insurance mechanism is actually adding, sort of bifurcating our current coverage and actually adding another administrative entity layer within our already bifurcated kind of insurance world. If you're talking about let's create a kind of what we've done, like let's bring all these streams together of funding and pay primary care in a comprehensive, like bundled payment, I think we should definitely be thinking in that direction. I do, and our primary care members have some concerns about adding another insurance form of insurance on top of an already complex insurance system.
So like, just to clarify that I'm understanding, that there would be concerns about splitting the primary care portion off of commercial health insurance, but not necessarily concerns about having commercial health insurance pay into a primary care system that everyone has access to regardless of their insurance status?
Sure. I think that is a fantastic summary. Thank you. You said that very well.
Okay, I'll leave it there for now. I'm trying to that was helpful, so thank you. And the main thing would be getting the numbers, so we have an idea of what it would cost to keep our primary care provider solvent.
Thank you for an overview of RBRVS, because you know I love RBRVS.
I know you love I know you love this.
Yeah, go ahead.
Okay, as far as the medical society, providers, how long have they known about this new maybe implementation of reference-based pricing? What's the feedback that you've gotten from these? I know it's kind of
largely I have gotten questions. I will say, of what will this mean for us? And and there's not a clear answer because again, it depends what you set the payment at. I mean, because as a concept, it's not a bad concept of let's look at what we pay for X service, but it all depends on then what are you paying for that service and how does that compare to what you're receiving currently? It's
it's going to be a difficult situation because you could have providers leaving. You could have providers unhappy with some of the agencies in a small hospital compared to UVM. So there's a lot to think about, and I hope we realize the unintended consequences of all this.
And I think that, there could be winners and losers, right? It depends what a current service is being reimbursed at different locations. For some, it could actually bring them up, and for some, it could be bringing them down. And for which service and how does all that play out? I mean, it's quite complicated. Oh, and I meant to say, I think I sent to your clerk, and I'm not sure if it's posted because I know there were questions about site neutral payments. This is an area the state and Green Mountain Care Board spent hours and hours on up until about 2017, 2018, when the outcome at the time, not the outcome, but one of the decisions was sort of, the all payer model might really get us away from fee for service. We might really be looking at alternative payments for everything. So kind of how much energy do we pour into this now? But there has been a lot of prior history work groups on that issue. I don't have all the details in my head, but I will say I did send in a really nice report that summarizes kind of all the work, not all, much of the work the state has done to look at this. I think the report was filed in maybe early 2018. So if you want the history of the work on that issue, I included that.
I had some questions that were building upon Brian. And in relation to this bill. So reference-based pricing, essentially, it's kind of built on the value that Medicare has given to various types of services, be they either physician services or even hospital facility. So, and thinking in relation, particularly, there's this section 5 at the end of number 5 at the end of section 3. So the capitated, or what I refer to as a capitated model, I think you said what is the term that we're using now for giving a set fee to primary care?
Yeah, capitated, yes, could be part of that, yeah.
I think there's a lot of things about fee for service because it incentivizes providing more services. Because that's how you're able to earn money, the more volume, provide more services. And there's stuff that's inherently bad about that. On the converse, though, when you talk about a capitated model, how do you generate revenue using a capitated model? You generate revenue by having as many patients as possible. Which then de-incentivizes you to actually provide services to those patients because you have so many patients that you can no longer serve all the patients that you're getting a capitated payment for. So how do we make a balance between those two things? Because your suggestion is that we change to have AHS essentially look at around primary care model. So how do we get to that? How do we blend the two together? I mean, I've always made the argument that fee for service doesn't work for a lot of care, but the one level of care that fee for service actually does work for is primary care, because it means you're incentivizing seeing as many patients as you possibly can, which is good for patients.
It can be, unless it means you are requiring patients to come in for an in-person visit that you could answer via a portal message or a telephone call. Like I'm here, our current president is a primary care physician whose site is struggling financially, and they are struggling with, I don't think I need to actually see that. I could answer this in a 1-minute phone call. But I'm spending 3 hours a day on the phone and not billing for any of those services. So I now need to bring every patient in, even if they really don't need it. So I think it's a balance with what quality measures you're using or what you are, measuring to make sure you are not seeing unanticipated consequences, patient satisfaction, patient outcomes, absolutely. You don't want to be incentivizing not seeing patients because you have too many patients. And you want folks to have a big enough panel that there's access. But I also think some of the frustration in primary care right now is that, and why we were pushing for things like reimbursement for telehealth, is like, we want flexible models. We don't want the patient to have to always come in, see the doctor or nurse practitioner or PA. Maybe they could actually just have a phone call with the nurse or a group visit, or we want flexible ways of providing care. So I do think you're absolutely right. You've hit on all of the risks and benefits of different payment models. And so I think with that capitated model, it may not be all capitated, it may be partially capitated, or it may be capitated with, really monitoring quality and outcomes to make sure we're not seeing some of those unintended consequences. I think there are ways to try to strike a balance.
The inverse of your example, though, is true the other way, which is if I'm capitated, why on earth would I be open on a Saturday or Sunday or in the evening when a patient calls me? All I have to do is send them to the emergency room. I'm going to get paid no matter what, same amount.
Well,
How do we set the capitation so that we're incentivizing that you're providing all the services that we say that we want in a comprehensive primary care setting? How do we set that to ensure that we're not having the inverse happen, which is, I'm just going to say this idea. And I think our ED utilization would prove that that's actually happening.
if you look at the NCQA standards, so this would become a blueprint practice in Vermont, you need national, what does that stand for? And I won't even try. NCQA certification, which is quite a time-consuming, rigorous application and part of that is things like enhanced hours and wraparound services and on-call services. I mean, so that's why I guess I balance that with what are we looking at to make sure primary care is meeting what we want primary care to do? I think there's quite a bit of that. And if we needed to look at other, and things, also one of the blueprint, I believe, metrics, and I know one of the ahead metrics would be ED utilization. So, so are we seeing that change? I'm sorry, I think Daisy.
I was gonna say, similar to what you said, all of these federal models have quality requirements and measures that you have to fit to in order to receive any sort of enhanced reimbursement rate. And so they do provide those guardrails so people aren't just willy-nillying their way to a really nice rate and people aren't getting the care that they need when they need it.
I'm going to go with Leslie and then.
Council quality assurance.
Thank you. I could not have come up with that myself.
But I want to reinforce the idea, and you said it, of what you're measuring. Because you're not only measuring that one thing, you're measuring many things about patient care, quality, all kinds of metrics. And I don't, I haven't worked in primary care for 5 years, 6 years, but I never thought about it that way. I mean, we didn't have global budgets and it was fee for service, but I never thought about it, getting paid. We just saw who was in front of us because that was what was done, right? So I worry about that as I don't think it's a perverse incentive. I think there are perverse incentives for fee for service, but I just don't think it works in primary care.
Well, opens the question of what actually is quality care.
Well, it might change from person to person. I
Mhm.
mean, it's hugely
How do we
varied.
measure it?
Well, there are things that you can measure, for sure. It's hard, but we can do hard things, and we won't always get the measures right, but it's a percentage of something.
Just anecdotally, my primary care, she's busy seeing patients. She's not going to watch this.
You better not be.
She always says to me, she says, my biggest quality measure is how many hugs I got that day.
No,
Right.
I mean, but we don't measure that. But what is the relationship between how do you measure the relationship that someone has, the therapeutic relationship that somebody has with their primary care provider?
Well, there's Press Ganey and there are other measures. We may not like them, but there is opportunity.
I will venture to say primary care is probably the most measured and reported on in anything in healthcare. And if you add one more measure to primary care, they will probably explode. And so I think it's it's like, how do we look at those measures and make sure we're looking at the things we care about? If we are changing how we pay, but I venture to say we probably don't need to add more measures, but just use what we're looking, take some away and really look at the few we really care about. Yes.
How much did you get?
Yes, I think I would agree with that.
But not everyone works. Sorry.
As a person who is a little more knowledgeable about our system than others, I have a disincentive to asking things of my primary care provider. And I told her that I really don't want it. Even if it's a message through the secure chat. And when I'm in an office setting with her, I'm acutely aware of how much time they're allowed to see me, so
I think there's some statistic, and I don't have it in front of me right now, but if primary care were to do every recommended question and screening in an appointment, it would take like 5 hours or something, something like there's just no, we've asked primary care to do so much. And I don't think the payment systems we have currently are making it better. With the, asking, you get this dollar per month if you do this, and you get this dollar a month if you do that. And so that's sort of our ask of, can we come around the table and look at, can we simplify, make it more one comprehensive funding stream?
Leslie, and, oh, wait, Brian, I'm sorry, Brian had a question, so
And I'll go after you.
We should have the doctors wear body cameras to measure their hugs.
Oh, there you go. Amen.
Or have AI monitoring everything they do through the medical record system. Oh, wait, that's starting to happen. So seriously though, just back to the chair's point about incentives to provide extra versus, I don't know, what you would call like enabling someone to do the minimum. Maybe that's the opposite of incentives to go above and beyond. A question I have is like, what is the balance? Because there's like the minimum needed to keep a practice open, but then my understanding, and I as a provider, I don't have to function the way primary care offices do yet, and I hope I never have to, or I'll probably stop, honestly. Because I like you said about the measures, it's unbearable at this point, like the administrative burdens that are being put on providers. And then the barriers to getting paid and chasing after insurance companies, no offense to insurance companies, or like, or chasing after patients to pay their copays or deductibles. It's getting really to be too much. So if we gave providers, my understanding is Medicare will give a minimum payment and then you get a bonus if you can prove outcome. Like I don't have to do it yet, but I can't remember what the acronym is, but it's like PQM, or there's like, you have to choose certain measurement.
MIPS.
Yeah. So
This is coming.
yeah. So can you tell us what it means before I go on further?
MIPS is the merit-based incentive payment system, I think, something like that. And it is a value-based component to Medicare fee-for-service payments that Vermont practices that have participated in OneCare have been exempt from. That is going away at least for probably forever, but at least for 2026.
And so what this means, in my understanding, is like you have to somehow I think it's in your billing.
In your electronic medical
I
record.
don't know how they check it yet. So, and we don't need to get into the details, but basically you have to report quality measures, and then you get a bonus. And then if you don't participate, you get paid less than everyone else. And so like if you're not a provider participating, you get like a 5% or whatever it is pay cut for not participating. So it's like you get less if you don't participate, you get a certain minimum amount if you participate. And then if you can prove using some kind of measurement tool that scientists have devised that you're like collecting data on, then which those things can always be swayed by how you're collecting data, you can get a bonus. But I guess what I'm getting at is, how do we make sure that people don't just collect that minimum or don't find ways to try to game the system and get the bonus? I'm not saying they're doing that, but that has happened. There has been fraud in the past in the world, maybe not so much in Vermont, but I know in like states like Florida, they regularly bust healthcare providers. So what I'm getting at is, just to the chair's point, like, we could give people the minimum, but then how do we make sure that they're not doing the minimum or sub-minimum? But then the other side is, how do we incentivize people going above and beyond? I know that when I go to my primary care provider, I feel rushed. No offense to them, but like I always feel like I'm an inconvenience. And it's rushed. And they're trying, but it's like they're stressed out. And every single person is rushing me. The nurse is rushing me, the provider is. And I remember that when I was younger, you would go to the doctor and it would be like this half-hour thing where I would get on a table and they would like poke me and do all these things and talk about things. And like, now it's like, often I feel like I'm being pushed to telehealth and it's rushed. It's just this, like, you're waiting an hour on telehealth and then it's this 10-minute thing and then you get like a $100 bill. So I don't know. I just think that doesn't really work well.
Daisy, that's why we're doing this, Phil.
But I don't know if you have any
I also wanted to say that you know, the quadruple aim of healthcare, I think is basically the stream that we've waded into. And it has been measured. There are multiple ways of coming at it. And I think in some of these quality measures and the things that Jess has talked about are in ways reflecting that fact that, you know, our federal administration in past at least has tried to support that at a state level. But yes, the administrative burden is significant and the cost of measuring that and implementing it is incredibly expensive. And I think some of the things we see in the bill, like the EHR alignment, the data alignment and contribution, allows us to do some cross-system learning potentially to, you know, that benefits our entire system. And so I think, you know, if anybody's interested, I geek out on this stuff, the practice improvement stuff. Google quadruple aim of healthcare. I know DMH mentioned it in their 2030 report. So it has been around and there's some really interesting things that other states have done with that.
And in terms of alignment, I think continuing to look at how we can align the quality measures. And that is something that OneCare really did bring to the table. And I think the state can continue, which is, can we count, you know, let's agree on what we want primary care to measure and focus on those things. Can we get commercial payers, the blueprint, you know, everybody to kind of agree, these are the things ahead. And, you know, luckily it looks like what ahead is measuring is largely what Vermont has been measuring. MIPS luckily seems to align pretty well with blueprint measurements. So can we prevent the add-on, the pile-on? Like, now we care about this, so measure these 5 things. Now we care about this, measure these 5 things in primary care in particular.
Couple more comments and then I think we're going to take a break.
Yeah, mine's more of a question.
Okay, Leslie, do you want to really?
Well, what I'd like to say is, you know, when you talk about 5 hours to actually get the job done, I think I would really like to have a conversation about people working at the top of their license so that they don't have to do all the stuff that other people can do. They're community health workers. There are other models that we can think about. And maybe we think about it in here somewhere where we look at what we expect. You keep saying provider, like expect the entire thing by the provider. I think it should be by practice, and really spread it away from an individual, but from what the whole practice can accomplish. I don't know how you measure that. I mean, what constitutes a practice is an interesting question, but maybe there are sort of bubbles of practice.
I completely agree. And I think there are a lot of really good models about team-based care. Yeah. And I think the blueprint and mental health integration pilot was really looking at that. How do we build up the team around the practice and the patient?
And remove the pressure from the provider, and so that there is the time and people don't feel like they have to move on. So that's sort of my imagination.
Unless box clicking, like, oh,
what's clicking? We'll talk about clicking, but yeah, that's a whole nother one.
Yeah. I have a question. Yeah, but I just want to say first, like, I don't mean to be harsh to other healthcare providers because I'm going through it myself. It's just that we're in this untenable work environment right now that's getting worse and worse and worse. And then it affects us as patients too, when we need care and then we're not getting the care we need. So it's ridiculous. But the question I have is, just after hearing the discussion, it's like, I don't like yes or no questions. Okay, here we go. How might a centralized sort of communal medical record system that is designed to collect data, you know, where measurement is designed into the system, how might such a system reduce administrative burden, and could AI be ethically used in that system to assist providers in you know, not only the documentation of care, but maybe even in the delivery of care? Because I know, like, there's something with medication, there's an evidence-based practice, like a check. I can't remember. I'm looking at the prescriber. Well, you're not a prescriber actually, but I'm like looking to prescribers for what it's called, where like it's like a medication management thing where like you use a checklist. Like there could be ways. I know Mari said less boxes to check, but it could be that the medical record system is strategic about what boxes it's asking you to check, if that makes sense. like, could AI or algorithms embedded in some kind of state sponsored medical record system reduce administrative burden? And while measuring the data for everyone?
Yeah, so, okay, I think, yes.
How much?
A multiple part question, but let me start with the AI question alone. I think there is a lot of potential for AI to help reduce administrative burden and filter the medical, the notes to the right key terms that could fill in the quality measure boxes. I think there are, program, companies and pilots looking at how to do that ethically and accurately. I mean, accuracy is probably the big issue, but yes, I think we can, hopefully, there is some technology that can help reduce the administrative burden. I mean, the fourth leg of the quadruple aim is provider well-being. And I think we're seeing it not just feeling like patients feel rushed, but this is why we don't have enough primary care clinicians, among other reasons, is they are leaving, they are retiring. So let's hope technology can help with some of it. Because I think prior technology promises have not come to fruition. I think getting on one statewide electronic medical record would be very difficult for many reasons. It's very expensive to transition to new medical records. The platforms that some of the larger entities in Vermont are on would be very expensive for smaller providers to transition to. Not everybody wants to transition because they've been able to customize their system for what they're on. I think, having talked to some other folks in the more IT world, the bigger help may be better interoperability, better ability for the systems to talk to each other and feed accurately into the health information exchange so that information can then get back out. Working on those connections rather than saying everybody has to be on the exact same platform might be the better. Like now, Macs and PCs can largely talk to each other and you can send records to each other. Like that is the better model to think about than everybody has to be on a Mac. So I think the state really is moving in that direction and can talk to Vital and others talk about the work they're doing to try to improve the ability of these systems to accurately talk to each other. But yes, I think we should definitely as a state be thinking of how can we not only use AI, but central, agree on the measures and how do we get those measures out of the data sources we already have. Some quality measures can be taken right out of the chart and you don't need to be providing records. You don't need to be filling out boxes and clicking things. So how do we streamline those processes?
I hear that. So I guess a follow-up question to it is, if we can improve interoperability, and that might help with the data collection and the sharing of information, which to me is actually the more important thing, like providers being able to know what they need to know to provide the care. But how does that control costs? Because these privately owned companies that are creating medical record systems are, from what I'm seeing, like drastically increasing their costs right now. And as they add AI in, they're like doubling the cost. And AI is very cost not effective. It burns a lot of fossil fuels to run AI systems. So I'm just curious, like if VMS or anyone who talks today has any ideas about how to control the cost if we continue to allow private companies to profit off of the healthcare system, the medical record system, and EHR systems.
I don't have an answer.
Okay.
These are expensive proprietary platforms.
Yeah.
It is a problem.
Yeah.
And can we look at things like, there are some options that I think providers in Vermont are already using, like shared licensing. So maybe it's a larger entity that has the license and you can have some sub licenses for smaller providers and kind of share the technology and talk to each other about how we can use what we have effectively. Unfortunately, I don't know that it would be much easier or less expensive for Vermont, for example, to build its own EHR. I mean, I think for better or worse, that ship has kind of sailed and we have folks who are so, established on their EHRs, and to actually switch to another system would probably, and develop a new system at this point would probably be much more expensive and, than, building on and improving the connections with what we have.
Don't do it.
I don't know. I hear that, but I've worked at agencies where we've changed the medical record system repeatedly over time. It's like changed. So
I can't imagine UVM Health Network. It's massive. Their electronic health record is massive. It has all sorts of capabilities built into it around billing and coding that talks to what you were talking about, gathering data easier and making the providers click fewer boxes. it would be a huge experiment, a huge disruption.
And years.
But what if everyone out of
Years.
business? Just saying, like, you know, so
It's a big issue.
What if we-
23andMe's going out
Vermont
of
went out of business?
I think we should take a break.
Speaking of going out of business, that's it.
Oh, I've had flashbacks to the times that I've had to
Unbelievable.
transition on EMR. We would lose half of our primary care workforce if we did that.
It would be the end of the world.
Let's be back here at 10:45.